to illustrate an integrative multidisciplinary approach to sleep disorder breathing. The patient's features were covered to preserve their identity. The main complaint was excessive tiredness, lack of concentration, and severe daily migraine. We want to assess our patients like we use our photographic camera, not starting with the teeth. We want to start by observing their bodies. We look for body posture and postural compensations. We start to see some alteration on his posture. Next, we examine the craniofacial profile. We can see the venous pooling, the dark circles around the eyes, an asymmetry of the face. There are postural compensation of this patient to open his airway, trying to breathe. Could that be accounting for some of his symptoms like his daily migraine? We examine the patient's profile. We analyze the proportions and symmetries. We look for facial asymmetries and measure their facial proportions. We make a thorough assessment of their features. We analyze their vertical plane. Only then we move on to the upper airway evaluation. We start with an extraoral assessment. How are their nasal aperture? Is there a neck deviation? We now move to the upper airway intraoral assessment. And as part of the assessment, we carry out a CBCT scan to look at their airway volume. We need to look at TMJ. Is there any deviation? Is there any bone degeneration? All of these need to be part of our investigation with good quality images. Only then we look inside the mouth. We do our intraoral assessment where we classify any malocclusion. And we record any relevant information such as previous orthodontic treatment or extractions. We carefully note any relevant signs. We look at the vertical and horizontal plane and do the midline assessment. Next, we take intraoral photographs and scans, including any relevant images. We zoom in further to do our soft tissue assessment. We look at intraoral mucosas, any sign of soreness, redness, dryness, or signs of oral cancer. We do our frenum assessment, upper, lower lip. An important part of the evaluation is the tongue tie assessment, the tongue function and nose breathing investigation. We take measurements, pictures, and videos. If we need a tongue tie release, we can start to think about our teamwork. Who will release it? Who will do the myofunctional therapy? We assess for parafunctional habits. We look for signs of atypical swallow. We also check for mouth breathing. If the patients have a reverse swallow or mouth breathing, we must reestablish proper function and need to start to think about myofunctional therapy. We now move on to the airway and sleep evaluation. We do a complete airway evaluation using CBCT scan, where we measure the airway volume and look for any obstruction. We look at the cephalometric analysis. And now it's time to look at the sleep test. This is a sleep report of one of the nights of this patient. It's well known that sleep disorder breathing gets worse over time. In this case, the patient is only 25 years old and is getting already a very bad quality of sleep. He presents severe apnea-hypopnea index. Over 50% of his sleep should be stable or deep sleep, but he's only getting 31%. He spends 37% of the time with an unstable sleep. This is more than the maximum expected of 30%. His sleep is very fragmented. No wonder he's always tired, despite reporting sleeping for over 90 hours a day. Once the records are uploaded to the clouds, a team of Airway specialists will help to analyze the recorded data. And an Airway intelligence report is generated. The Airway intelligence report will include health history, CBCT evaluation, photographs, intraoral records, and his sleep report. And the comparative of all his craniofacial measurements with the normal limit standards. These reports can be used to present to the patient in a concise and visual way, and to the team of selected healthcare providers that will be working in his case with us. Now is the time that we're planning. At this stage, we can start to think about the group of healthcare providers we want to work with us. We need the tongue tie release. We need myofunctional therapy. We need to see an ear and nose, throat doctor. We need to be seen a chiropractor or an osteopath. We need an allergist doctor, a pulmonary sleep doctor to look into his sleep study. Should we refer him to a neurologist to check his migraine? So this is all integrated in our treatment plan. As we look closer, we can start to correlate his symptoms with his findings. For instance, his occipital atlas distance is around 5 millimeters, when it should be around 10. Could this be accounting for his daily migraine by pressing down important structures? His left condyle is very posteriorized. Could this also be influencing his migraine? We also think about at 25 years old. At 25 years old, this patient is already presenting bone degeneration on the left condyle head with beginning of beaking. You can visualize the craniofacial discrepancies and start to think of possible vertebral deviation for compensation, and be already planning for the involvement of chiropractors or osteopaths for the evaluation and concomitant treatment of this patient. His soft palate length is 42 millimeters. That's 7 millimeters above what the average should be. This will be a factor that can be accounting for the obstruction of his airway, and we need to work with the ENT doctor. We may want to consider treating him with night laser, low power laser treatment that improves the elasticity of the soft palate whilst we are undergoing expansions of the airway. The ENT doctor we need to evaluate him for septal deviation, nasal space, and possible allergies. Forward head posture is common on patients with obstructive respiratory disorders. This position is adopted in order to facilitate breathing and is common in mouth breathers. Studies have shown a return to normal in patients with treated enlarged adenoids, in patients with reestablishment of physiological nasal breathing and adequate tongue positioning. This emphasizes the importance of multidisciplinary team approach, where we work closely with the ENT doctor, the chiropractitioner, the myofunctional therapist, and so on. The patient was sent for a chiropractic evaluation and treatment of compensatory misalignment. He provided a detailed report on his condition and initiated treatment in a coordinated way. This is part of his detailed evaluation report. I will not go into details, but it's important to see how a teamwork approach can improve the health of our patients. He made a detailed analysis of the problem and sent me the report in writing. The patient had postural compensations and some rotated cervical vertebrae. After the first adjustment, the patient already reported improvement in his migraine and neck tension. The treatment plan for this patient involved a team of healthcare professionals with dentistry at the core. The team comprises of the dentist, me, as the core provider for craniofacial and airway growth, and for the tongue tie release at some point. For the growth, a biomimetic removable intraoral appliance, FDA approved for the treatment of obstructive sleep apnea, is being used. This is a non-invasive option that treats the root cause of the obstruction. We chose to work with a chiropractor and osteopath for cervical and body realignment, the ENT doctor for treatment of allergy desensitization and evaluation of nose obstructions, the pulmonologist, sleep doctor for the full sleep disorder evaluation, myofunctional therapist to reestablish tongue and breathing function, a functional doctor, a nutritionist to check his long history of low BMI and reestablish his overall health, and a neurologist for a full evaluation of his migraine. In 3 months evaluation, so far, patient has drastically reduced the recurrence of his daily migraine, has gained some space for his tongue, as we have seen some growth of the upper arch as the removable intraoral device is gradually adjusted. He's getting some space with his expansion. Although it's only 3 months, we can see his deep bite being gradually reduced. There is still a long way to go, but his profile has greatly improved. His forward neck posture has been reduced. He gained some color and is starting to look healthier. And overall, he seems a happier patient.